Good afternoon, everybody. It's a pleasure and a privilege to be here. I want to start by thanking all of you for taking the time to be here. I want to thank CVRX for sponsoring this event. And I want to thank our phenomenal faculty, Dr. Allred and Dr. Vadim, who will be participating in today's symposium, really elaborating on the new technology of Barostim. We're going to break this session up into three parts. I'm going to talk about how we got here. Dr. Vadim will talk about where are we right now. And Dr. Allred will tell us some things about where we are potentially going in the future. So it's going to be really an interesting symposium, and I hope there's a lot to glean from it. So let me start by really setting the stage for device therapy for HFrEF, or heart failure with reduced ejection fraction. There are many forms of treating patients with heart failure with reduced ejection fraction beyond guideline medical therapy. And we know many of these patients have associated moderate to mitral regurgitation, mitral regurgitation that may require transcatheter repair. They may have atrial fibrillation that may require associated ablations. Many of them have a wide QRS and do really well with cardiac resynchronization therapy, but there's this whole subset of patients with HFrEF where CRT doesn't really work that well. And if you look at the subset of patients with heart failure with reduced ejection fraction, it's a large number, and only 30% of those patients actually are eligible for cardiac resynchronization therapy. 70% of those patients either have a non-left bundle branch block that is less than 150 milliseconds or have a narrow QRS that really don't make them eligible for cardiac resynchronization therapy. So we're very excited by the potential of some of the newer strategies that can help us manage this subset of patients out here. So how has device therapy really evolved over the years? So this goes back several years. I think, it is in 1985 that the first ICD was approved, which I think we all know that Dr. Marowski and Dr. Maurer really kind of created that new paradigm for how we treat patients with sudden cardiac arrest. It was subsequently in 1996 that after a slew of studies that ICDs then got approved for primary prevention. And then we had, in 2002, we had cardiac resynchronization therapy, which was developed, which is largely to treat patients who had a wide QRS, who had evidence of electrical and mechanical desynchrony, where CRT was able to change the course of their lives. Now, over the course of the next 17 years or so, there's been a lot of progress, a lot of studies, and since cardiac resynchronization therapy works so well, it was tried in patients with narrow QRS. So as you know, there was this slew of studies with narrow QRS who had associated mechanical desynchrony, which was elicited by echocardiography, and whether it was the RETHINK study or the Lesser Earth study or the Echo CRT study or the narrow QRS study, all of them were actually neutral to negative for resynchronization therapy. In fact, the Echo CRT study, which I had the honor or notoriety of co-leading, actually saw that CRT increased mortality in patients who had a narrow QRS with heart failure. This then brought in the realm of autonomic modulation. And that brought in spinal cord stimulation, which we know was defeated by the DEFEAT study, which really showed that spinal cord stimulation does not help patients with heart failure. And then we had a slew of studies looking at vagal nerve stimulation. This is the NECTAR-HF study and the INNOVATE-HF study. Again, both of them being neutral studies, and obviously we're waiting for the ANTHEM-HFrEF study, which hopefully will have its results in the next year or so. But really, vagal nerve stimulation has not panned out for treating this patient's population with heart failure. And this brings us to Baroreflex Activation Therapy. Now, this is a therapy, as we know, has been FDA approved in 2019 for patients with an ejection fraction of less than 35%, class 3 NYHA on optimal medical therapy. This therapy basically involves putting an electrode over the carotid bifurcation, connected to a little device, and stimulation of the device changes the sympathovagal balance. It increases the parasympathetic tone, it decreases the sympathetic tone, it reduces heart rate, and at the same time causes natriuresis and diuresis and actually translates into better outcomes for heart failure. There is this whole spectrum of autonomic studies that potentially could be done, but of these different areas, whether it's the tragus, the vagus, renal denervation, or intrinsic cardiac autonomic ganglia ablation or stimulation, the only one that has panned out so far is Baroreflex Activation Therapy out here. So I'm really excited about the potential for this field. And with that, I'm going to pass on the mantle out here to Dr. Fudeem. And let me get the slides set up for him. Now, Marath is an assistant professor at Duke. He is an advanced heart failure doctor and has done a lot of work in the field of autonomics. So much so there's a lot of work in splanchnic autonomic blockade and stuff. So we're very excited to have you here present some of the data with respect to Baroreflex.
I wish you wouldn't have disclosed as I'm a heart failure guy. I tried to be incognito. All right, so we're going to start off by talking about the baroreflex. And the key observation here is that the baroreflex is downregulated, is less sensitive in patients with heart failure as compared to patients that don't have heart failure. And that's true, by the way, for HFrEF, reduced or preserved ejection fraction. So the question then will become, as Dr. Singh alluded to, can we then maybe stimulate this reflex loop in order to improve the cardiovascular conditions and its outcomes? So the problem at hand is that in heart failure, many of the reflex mechanisms, such as the chemoreceptors, the baroreceptors, there are baroreceptors throughout the cardiopulmonary system. It's actually not just in the carotid artery, it's also in the pulmonary arteries, it's in the lungs itself, and the kidneys. They are known to be either overactivated or suppressed inappropriately, and many of those have been targets as alluded to earlier. But the baroreflex is actually one of the key mechanisms, or the key reflex loops. I sort of call it the king mechanism. It's actually subordinate to other mechanisms. And in systolic heart failure, as it is in diastolic heart failure actually, the baroreflex is downregulated. And what is shown here is the so-called slope. And the slope is intended to demonstrate that with, for example, positive pressure exhibited upon the baroreflex. So the reflex works the way, if it senses positive pressure, it downregulates the arterial vascular tone, downregulates the heart rate. It's a protective mechanism to protect the brain from too high or too low pressure. You can measure that slope. And on the right side, you see that in heart failure, that sensitivity is downregulated. We know that that sensitivity is downregulated even further the worse your heart failure is, as measured by NYHA class 2 or 3 here on the bottom to the right side. And maybe to no surprise, the more downregulated your baroreflex is, the worse the associated mortality. This might or might not be causal, but certainly the association here is quite strong. So then if you sum up what a downregulated baroreflex might be associated with in heart failure, it's actually quite detrimental. It not only leads to an overactivation of the sympathetic tone, but it also leads to an inappropriate secretion of RAS system hormones, the catecholamines. It is possibly directly then associated with increased filling pressures and worsening biomarkers such as NT-proBNP. But if you can imagine, since this is such a hierarchically overriding mechanism, that it might be actually then down the line also be associated with worse outcomes. So could it then be possible that if we stimulate this reflex and actually rebalance the system, could we improve upon the detrimental effects by this downregulation? So I will show you now just an example of the studies that are out there that are either preclinical, so animal studies, or clinical in a small fashion that will demonstrate to you hopefully how those mechanisms are getting improved upon with barostimulation. So this is one of the few animal studies I will show you, but dogs that were paced into heart failure, that's how you induce systolic heart failure in preclinical models. They were either subject to stimulation with the baroreceptor activation system or not. And what they found is that those dogs that were stimulated, first of all, had greater survival when they were not stimulated at the baroreflex. And the underlying physiology that was improved, they had actually less catecholamines or angiotensin being spilled over into the blood. And that was the mechanism likely driving some of the benefits seen by baroreflex stimulation. Then moving into humans, actually, one of the first projects by Nina Braunwald, that's Eugene Braunwald's first wife. She passed away, unfortunately. They actually stimulated the baroreflex back in the 60s for the treatment of intractable angina. So back then, besides nitrates, they didn't have really much. And they noted that you can stimulate the baroreflex and your blood pressure and your heart rate dip lower. And so they started to exercise people and see whether they can affect exertional angina in patients. What they were able to find is that with this old system back then, they were able to improve angina, able to improve how far patients exercised, and were able to do that at a lower cost to the system, aka lower heart rate and lower blood pressure. Of course, the system didn't pan out till then, later the 2000s, where this system was introduced that we're talking here about in a second. So if you now apply this in humans, the sympathetic nerve activity goes down, the baroreflex sensitivity goes up. And this is not just an acute event, that actually persists for months at a time if you measure it serially in patients. And then also to translate into PV loops, I can't give a talk without PV loops in it. The idea here for this one case scenario with HFpEF patients is that in patients where you activate the baroreflex acutely, you have a reduction in filling pressures, as shown here on the right side in the green box. The 19 to 13 is a drop in the LV-EDP, left ventricular end diastolic pressure, which is the wedge pressure. But you also see an increase in stroke volume. That's the blue versus the red curve. So you increase the stroke volume, you decrease the filling pressures, which is really a surrogate that you change not only cardiac parameters, but also change the vascular compliance that leads to those changes. So the effects on the body are actually quite more far-reaching than just the heart itself, and that's the key. So now I owe you, to go beyond those surrogate markers, the mechanistic components, and see if we can actually affect the clinically relevant endpoints. And for that, we need to go into the BEAT-HF phase 3 study, which actually led to the approval of the technology. This was a randomized controlled study where the Barostim system was compared to control patients. And here, first of all, of course, as for every study, we wanted to make sure that the device is safe. So the device was found to be safe. There were very few adverse clinical events. Further, the clinical endpoints of interest were here exercise capacity, which improved by 60 meters. We find anything above 30, 25 meters to be clinically significant. So that's quite far-reaching. Same thing for quality of life. More negative is better. This is with Minnesota living with heart failure. Anything more than 5 really is considered to be clinically significant. Reduction of 14 points here compared to the control group, and an improvement in NYHA class in 34% of the cases. At the bottom, since I'm talking to an EP audience, is the comparison to CRT trials. So how did CRT trials compare to this data? And if you see, for example, contact on a Miracle, 39-29 for 6-minute walk distance. So the improvement seen for all of those 3 clinical endpoints was greater than was observed, for example, the CRT trials, which were done in a somewhat different era, pre-GDMT, pre-gallant medical therapy. And then also, of course, a reduction in NT-proBNP was seen here, a 25% reduction when compared to the control group. So what I've shown you is that we can improve with this therapy heart failure symptoms, quality of life, and functional capacity as measured in a randomized controlled setting. What is currently pending is mortality and morbidity, and hopefully this data will be out within the next year or two. So stay tuned. And I think now off to you to introduce.
Great, thank you. Now we have Dr. Allred. You get slides this time. So Dr. Allred is the chief of electrophysiology at Greensboro, Moscone. Runs a really large practice out there and has done some really cutting-edge work with the Barostim technology. Very excited to have him out here today. Out of interest, it's just important to know that he's one of the only persons I know who's given an entire lecture without any slides because the slides failed the last time. So we're delighted that this time, hopefully, he'll have some slides. Perfect.
Perfect.
Thank you.
So Dr. Singh mentioned to us already that we have limitations in electrophysiology. 70% of patients are not candidates for CRT. And as an electrophysiologist who likes to make patients feel better, that doesn't settle well with me. I want to take care of patients in a way that improves things. I was talking to an electrophysiologist today, and he said, James, I don't have access to this therapy. A patient is referred back to me on optimal medical therapy with a narrow QRS, and he says, I have to say, I hope you feel better. And that's all he's got. I hope you feel better. That's all he's got. And so Dr. Fadim here today says we've got new therapy that can improve your exercise tolerance, can improve your quality of life, and your heart failure class. That's novel. A heart failure doctor here on stage telling us all these great things. It's great to be a part of this presentation today, and it's great to be in real life. I'm glad we're here, not virtual today, so I'm glad that you're all here. So you might say, well, as an electrophysiologist, we're talking about a device that's not thoracic. It's implanted by a vascular surgeon in the operating room for heart failure. Why, as an electrophysiologist, do I want to be a part of this therapy? The reason is because we want to do more for our patients, right? We don't want to look at that patient in the eye and just say, I hope you feel better. We want to do more for that patient. That's why we're here, and that's why we're learning about this therapy, and that's why I'm really excited about this. And so hopefully you'll pick up on some of this excitement as well. The first question, where do we get these patients? I'm an electrophysiologist. Where am I going to see patients that would benefit from this therapy that heart failure doctors are talking about? The first place we see these patients are our ICD patients. By definition, the majority of them have an ejection fraction of less than 35%. And the majority of them have heart failure. And hopefully these are all patients on good medical therapy. These are patients that come to you in your practice every single day. Patients who might have CRT but actually have not received benefit from therapy are now patients that we could consider for this. Patients who are frequently hospitalized. Maybe these patients bounce back on your schedule after a recent hospitalization for an arrhythmia, heart failure, decompensation, or other things, but these are patients to keep in mind. And then when you're having conversations with patients and they're talking about reductions in quality of life or activity, functional status, I can't shower, I can't make my bed, I can't cook, I can't climb stairs, I can't do all the things I want to do, think baroreflex activation therapy for that patient. Unfortunately, I think what we do too often is we see that patient and you say, well, he can't shop or travel like he used to. He's not, he was playing golf 5 days a week. He's rarely going at all, but he's not sick enough for this therapy. I'm going to wait until he's on his deathbed. And that's not what we need to do. This is a therapy that really helps our patients. I'm going to show you a couple of cases today of how patients can do so much better with this therapy, but this is not a bridge to transplant. This is not an alternative to VAD. This is for our patients who have recent, class 3 heart failure, maybe hospitalized, and could have now class 2 heart failure, but they need to feel or want to feel better. They need more. This example is one that is probably one of my favorites. It's a 36-year-old gentleman with a familial cardiomyopathy. He has New York Heart Association class 3B symptoms. His ejection fraction 15%. He's not had prior arrhythmias, but he can't tolerate medical therapy. He's one of these guys, you see him all the time. His systolic pressure is 80s and 90s at best. He's frequently hypotensive when he stands. He's on Coreg 3.125 and like 2.5 of lisinopril because that's all he can tolerate, and really he can't tolerate that. So he takes his Carvedil on Mondays and his lisinopril on Tuesdays. He just cannot tolerate medical therapy because his heart's so sick. And he's got a narrow QRS. And you're looking at this guy, and what you don't want to do is just say, I hope you feel better. I can't give you more medicines. I don't have anything else. You don't have a wide QRS. Can't resynchronize you. I hope you feel better. He's tired. He's short of breath. He has intractable edema, and he's getting worse in front of you. This gentleman was implanted with a Barostim device, and we followed him up at 3 months. At 3 months, his class 3B symptoms had improved slightly to class 3, and he had a little bit less edema, but no marked improvements. We titrated his therapy at that time. We saw him back at 6 months. Now he's class 2. He's starting to feel better. His energy's better. And most importantly for this patient, his hypotension has resolved. So guess what we can do now? Now we can titrate his medical therapy. And so we start to put him on Entresto, and we start titrating his beta blocker and all of these things. And at a year, this patient is New York Heart Association class 1. His edema is completely resolved. His ejection fraction is 25 to 30%. And this was a dying man when we saw him at the beginning of the year. Sorry, sir, I hope you feel better, right? So this is huge. This is what we're talking about. This is an opportunity to really intervene and impact the lives of your patients in an amazing way. Another patient, 78-year-old female, she has a non-ischemic cardiomyopathy. Over the course of about 3 years, she had decline initially. So she had an ejection fraction of 40%. She had a CRT-P device placed, and despite that, a year later, her ejection fraction has reduced further to 30%. Her device was upgraded to CRT-D. She's another one with a fair bit of pump failure. She had a simple atrial tachycardia, and with that had syncope because her heart just could not tolerate any type of tachycardia. She did have an atrial flutter ablation. She was treated with medical therapy as tolerated, and in 2021, she underwent Barostim implant. New York Heart Association Class 3 symptoms, still having shortness of breath at first. She had AV node ablation due to ongoing arrhythmias. Her medicines were titrated. She did have ventricular tachycardia, ventricular fibrillation, which led to her Barostim implants subsequently thereafter. So the device was implanted. This is a very sick patient. 2 months after implant, she's feeling a lot better. She's feeling great overall. Last short of breath episode was several months ago, and her energy is starting to improve. We up-titrate her Barostim device. We're able to up-titrate medicines further, and we see her at 4 months. At 4 months, she's New York Heart Association Class 1-2, and she's had no further heart failure admissions. She's very happy. She's doing well. Again, a patient that we had done everything for. She had CRT. We had tried to optimize this device. We had done everything we could for this patient. Sorry, ma'am, I hope you feel better, right? But now we have new therapy, and she's done really, really well. Where's another place that we can get device patients for this procedure coming out of electrophysiology? We mentioned this list right here. For me in my practice, a huge opportunity is within our ICM clinic, where we look at thoracic impedances on a daily rate. This is a patient, he's a good friend of mine. I've followed him for about 10 years now. He started out with substance-related cardiomyopathy, had very little resources. He had basically cardiac cachexia, and he's just not done well for years. And basically for years, I've seen his core view look just like this. And we're up titrating, down titrating, doing what we can with medicines to try to help this gentleman. And he's had multiple admissions. And towards the end of last year in July, we implanted him with a Barostim device. And the core view tells the story. You know, this gentleman had his device implanted in July, and as you can see, as we've titrated therapies, he's done amazingly well. And so this is exciting, and this is, for me, an objective finding. You know, when we talk about improved quality of life, when we talk about improved exercise tolerance, when we talk about improved New York Heart Association class, that's what patients care about, but sometimes we're a little bit, well, those are fuzzy a little bit sometimes. But when we see things like this, for me, it gives me a objective, hard endpoint to say, wow, we helped this man. So let's talk about the implant technique. So currently, the device is implanted in the OR by our vascular surgeon. That has been an amazing collaboration for us, a really good teammate, and we've helped a lot of patients. They make a small incision in the neck and basically suture the device, the electrode, right onto the carotid bulb, then tunnel the lead down to a pectoral pocket, and then close that, similar to as what you would do with an implanted defibrillator type device. Again, this is done in the OR. Patients can go home the same day from this. It's a big deal. As an electrophysiologist, initially I would go in to make the pocket for the device, but over time I realized my vascular surgeon could do it just as well as I could. And so now he does these procedures himself from beginning to end, and does an amazing job, and has really bought into the process and has seen these patients get better and has realized their journey with me. There's a new procedure coming, right? Bat wire. This is an opportunity for percutaneous implantation of the device over a guide wire. So basically what would happen is, using ultrasound techniques, we're able to guide a wire right over the carotid bifurcation and then insert a lead in this location that we can then tunnel down to a pulse generator. This is an example of one of our cases. You can see in the top right picture that we're using ultrasound, and we're able to guide our needle to the carotid bifurcation, and then we take a guide wire and follow that through an entry point and an exit point of the skin, and then over that we're able to use our introducer to advance the lead to a location that we can confirm with ultrasound. It's then tunneled down to a pulse generator. And so now as an electrophysiologist, I can be even more excited about this technique, right? And this therapy for patients, because sure, my patients have another opportunity to feel better. We can improve their exercise tolerance, their quality of life, their New York Heart Association class, and now I can be a part of the procedure with the implant technique.
Thank you, James. That was an amazing talk, very insightful, and gives us a good idea of where the therapy is going in the future and how the implant strategy will become easier for electrophysiologists. While I'm waiting for questions from the audience, let me kind of start with a couple from my end. Are there any questions? Okay. So let me, Murad, this is for you. Most of the data right now is, as EPs would look at it, as soft data. Exercise capacity, 6-minute walk test. But I think a lot of heart failure cardiologists do state that many of these data actually translate into better outcomes. What are your thoughts about, one, is there mortality data or rehospitalization data around the corner, or what are your thoughts about the existing data with respect to its clinical applicability?
Yeah, so I agree that while we do refer to them as soft endpoints, I think this is a pure trialist approach to this. For patients, they're not soft. The ability to walk, 20-30% more, to have a better quality of life certainly matters a lot more to some degree than maybe being alive longer for 1 or 2 more months. That's sort of what you see in big clinical trials. Having said that, the chosen endpoints are chosen not simply because they matter to patients, but because they also translate into the heart outcomes, right? So an improvement in 6-minute walk distance, quality of life, is associated in other major clinical trials with a reduction in heart failure hospitalization and death. So it all does look like it would then be associated with better outcomes. Of course, only the trial will be able to tell. That data is currently still in follow-up, so I believe by the end of the day, the follow-up will be done, and whenever the data will be presented. I have no insight into that right now, but I have no doubt that it matters to patients and certainly has the best chance to translate in better outcomes. And that's why I did show in those slides the relationship to other clinical trials where a reduction in NT-proBNP was associated with better outcomes. That's a hard marker. If you improve NT-proBNP, it's very likely to result in better outcomes. That's sort of across clinical trials, it's just a truth.
Thank you. Extending off that, with respect to the daily management of these patients who have a baroreceptor stimulation device implanted, James, for you, you've dealt with a lot of these patients. Is there any particular strategy for up-titrating the dose that you use to stimulate, or up-titrating the medications, or do they work in concert, or it's one or the other?
I think they definitely work together. We typically try to, after implant, after everything is settled into place, we try to increase the titration of the device therapy up until a point the patient doesn't tolerate it. And what does that mean? Well, every patient's different. For some patient, it might be, there's just an unusual feeling in their neck. For some, it might be a buzzing or a vibration. Everyone is a little bit different, but we find the point at which they don't tolerate this, and then we back it down from there. But we want patients to be optimized, and we titrate this fairly aggressively. And then as our first case demonstrated, as their blood pressure improves, hopefully it gives us more room to work on their medicines.
A quick question, Murad, with respect to titration of the therapy and the medications, how do you envisage this set of patients will be managed? Is it going to be a heart failure or a heart failure EP combination, or are we going to have the vascular surgeon also involved? What is your picture of how these patients should be managed?
Well, we're setting it right now up in our institution. I think the key players here, of course, you need an implanter, and that's a vascular surgeon. So they would never say no to having more business sent their way. But I do not think that they necessarily need to be there for the device check thereafter, which is done by the reps by the company. They take on the entire titration scheme. It's not on the physician or the APP to do that. We have the EPs, or will we have the EPs involved for the pocket check? They're sort of the ones that can take it on right after. I don't know if it's in your institution, the vascular surgeon doing the pocket check or the EP side.
They usually follow within the electrophysiology wound clinic.
Right, so for us it will be, our plan is, it's the heart failure group that actually will follow and own the patients. There, it might be the EP group because they're a lot more involved with heart failure care. We have a little bit more of division of powers at our institution. So I think every institution has to figure out for themselves how they will do the follow-up, but the interconnectivity between heart failure and EP is bigger than ever before. It's CRTs, we have the other players, the CCM as well. I think we will not be able to separate those two, and if we learn to play in a sandbox together, this will make it easier for follow-up. But I think every institution will have to figure out for themselves.
Got it. And what about, looks like there's some questions from the audience. Before I take this question, a quick question to you, James. Now, is there any interaction between the device and the ICD? Because many of these patients have, or almost all have, ejection fraction less than 35%. I'm guessing most of them have ICDs, but have you encountered any interactions or noise that has been a deterrent to the use?
Great question. We have not. So at implant, what we would do is we would actually titrate the therapy to high output, and we would interrogate the ICD at that time just to make sure that there's no crosstalk or far field from that. And we've not seen with our experience any of that. It's very interesting though, when you get a surface EKG on patients that have this device implanted, there is a ton of noise on that surface EKG. So you would notice that, but none as far as we have seen with our ICDs.
There's a really interesting question from the audience out here. You're playing with the sympathovagal balance. You're regulating the autonomic tone. Is there any role in patients with POTS or dysautonomia that any of you have actually seen or could speculate what the potential role could be? Any thoughts on that? Either of the two of you.
Well, I do see patients as part of the dysautonomia clinic at Duke. It's an interesting thought. We certainly know that the autonomic system is dysregulated. I wouldn't even know whether it's upregulated or downregulated. It's dysregulated. I think it just doesn't respond the right way. I would argue that it's probably not going to be helpful to do this Barostim, because the reason is we actually use a lot of sympathomimetics in patients with dysautonomia, whether it's POTS or neurogenic orthostatic hypertension. So this therapy technically increase the parasympathetic tone and decrease the sympathetic tone. That's sort of what's the main effect is. You saw the muscle sympathetic nerve activity going down, out to 12 months. So I think it probably would not be the right therapy for at least some of the dysautonomia patients.
Just as an extension to that, is there an on-off effect when you turn off the baroreflex stimulation? I mean, do you find that muscle sympathetic activity just drops and comes back on? That's one question. The second one is there a tachyphylaxis effect? I mean, do the baroreceptors with constant stimulation become less responsive with time? Any thoughts? And either of you can go on that.
So, at implant, especially with our bat wire therapies now, where we're guiding this with ultrasound, we have an art line in place and we turn therapies on and we expect to immediately see a blood pressure drop. We in fact expect to immediately see a heart rate response, and when we turn it off, we also expect to see a rebound from that. So there is an on-off, at least as what we've observed in the OR with these. We've not seen tachyphylaxis. We've had several patients that we've done a 5-year generator change on, and they continue to benefit from therapy. So that's not something that we have seen in our practice.
What is the battery life? I mean, is the therapy continuous, and what is the battery life of a conventional Barostim device?
What we have seen so far is that it is continuous therapy, and the battery life is about 5 years. Yep.
Got it. And there are many questions actually popping up. It's amazing, actually. Thank you for those. Any issues with MRI with compatibility of the Barostim device, or is it an MRI compatible device?
You know, that's a great question. Do you know? I don't know.
Yeah, okay.
How about Paul?
Yeah, so excuse me, loud enough?
Yeah, perfect.
We have communicated publicly that we have submitted for FDA MRI.
Can you hold the mic a little closer?
We've submitted for MRI conditional approval, and we do expect that sometime in the near future.
Got it.
Look forward to communicating that.
Right. So another question that has come up, since, you know, one of the potential roles for modulating the autonomic tone could be treatment of hypertension, treatment of arrhythmias. Do you think there's any potential pro-arrhythmic effect by the sympathovagal balance being shifted, that you can have arrhythmias from this? Have you encountered any in your experience?
A really great question. We have not seen a pro-arrhythmic effect. I think one of the things I've worried about most has been worsening of bradycardia. You know, you see a patient who has a single chamber ICD and they come in for the procedure with a heart rate in the low 50s, and we're implanting this device. And so my concern has been, wow, are they going to be more bradycardic? Are we going to have an atrial lead added? And we've not seen that. And it's very interesting when you go back and look at BeAT-HF, there actually was not a statistical, over the course of the study, reduction in heart rate in these patients. But initially you do see at the time of turning it on, you see a bradycardic response, but over the course of time with patients, they seem to do just fine from a bradycardia standpoint. There is suggestion, as you mentioned, of a reduction perhaps in atrial fibrillation or ventricular arrhythmias. That's not really, I don't think we have enough data to now really say that that's the case, but there is some hint towards that. We have not seen a pro-arrhythmic effect in our population.
I think it's interesting also to note that, you know, I showed you Brownwald initially did it for anginal control due to vasodilation, heart rate reduction. But you know, the initial efforts by Barostim were also to treat hypertension. So uncontrolled hypertension was one of the early targets. Interestingly, when applied in patients with HFrEF already on good medical therapy, the antihypertensive effect really is not that bad. Meaning that if you have high blood pressure, you see some benefit on blood pressure. But if your blood pressure is in a normal or low zone, you do not have any additional decrease of blood pressure. The blood pressure remains stable, which I think is key, because one concern might be you will lower the blood pressure even more, but it's just not what you see. Maybe the opposite, you actually gain blood pressure back and you can titrate medications. So it's fascinating. I mean, to some degree, the term sounds maybe a little bit too simplistic, that it just rebalances the system, but it really does that, because it auto-titrates, for example, the blood pressure.
So could I speculate off what you just said, is that if you have a hypertensive phenotype of HFpEF, that Barostim potentially, if investigated in that subset of populations, could regulate the autonomic tone, adjust the blood pressure response, and probably be a therapy for the HFpEF population. Is that a logical extension?
I think that would be the combination of best worlds. You have the hypertensive component, if it's sympathetically driven, of course, which it is in most cases, and then HFpEF, I just showed you one of those cases was HFpEF, where the stroke volume increased, the intracardiac pressure decreased. I mean, yes, you could get the best of both worlds in that phenotype.
James, another question has come in for you, asking, do you always need an ultrasound for the percutaneous implant, or are there other strategies that could be used?
Absolutely, absolutely. This is an evolving technique, and my ultrasound skills have tremendously, advanced over the course of this trial and participating in it. But yeah, so this is, absolutely ultrasound guided therapies at this point. I'm not aware of any intentions to change that or to do it a different way.
All right, I think we're getting to the close of the session, but I'm going to ask you a question. I'd like both of you to speculate on this. You showed us that these patients have a significant improvement in their ejection fraction, and I think we've seen that in the BeAT-HF study, that these patients have actually done really well. If you were to get a patient narrow QRS, EF 30% on maximal medical therapy, I'm asking you to think out of the box out here. Would you be comfortable implanting a Barostim device as a first pass with a life vest and reevaluating the individual over time to see if the ejection fraction has evolved and gotten better and avoid an ICD completely, or or do you think we're pushing the frontiers by thinking ahead of ourselves?
We have had patients in our practice that have come and said, you know what, James, if I can't live better, I don't want to live longer. And so we have implanted this device in patients for improved quality of life that do not have ICDs. Some of those patients do feel better and they come back and say, I do, again, with shared decision making, right? These are all opportunities we have. And so they come back and say, now I'm feeling better and I would like to have an ICD implanted. And so we have done it that way. We have done the Barostim device first, followed by an ICD. Would I, have any data at this point to say that Barostim would be an alternative to ICD? I do not.
Fair enough.
Yeah, and I would argue, and I got to be careful, I'm at the EP conference here, but I think an ICD has no therapeutic benefit, with the exception of one time out of 100 life years, maybe somebody gets shocked with this. But a Barostim is a therapeutic device, and I think when you offer patients, for example, a CRTD, they're much more likely to say, oh yeah, it can actually improve my function. If that's how you talk to patients about the Barostim, it's actually a therapeutic device. And I completely agree. If you're in the borderline zone, for me, it's even 25 to 35. If GDMT is sort of doing already its magic, and if you consider this as an additional therapeutic intervention, I think patients are quite responsive to that, as opposed to just a safety net, which is an ICD. They will respond to that actually more likely to say, okay, let's try therapy first.
So on that note, I think it's a really exciting time. We have a disease-modifying therapy for heart failure with reduced ejection fraction who are not eligible for cardiac resynchronization therapy. Clearly, there's so much work to be done, so many studies that can potentially advance the field even more. And I thank the faculty for being here. I thank all of you for taking the time to be here, and thanks CVRX for sponsoring this symposium. Thank you all.